right, moving on to our third and final speaker for our webinar. And this now is Jane's turn. So we've moved from Scotland to the US and now we're going to Canada, and we're going to hear from Jane Francis. And Jane recently got a promotion. I will give you the shout out for that, Jane, because I missed it in in recent correspondence via our Nourishing Futures Network newsletter, which I encourage you all to sign up for. So Jane is a registered dietitian. She specialises in infant nutrition, and she's an assistant professor in the School of Nutrition and Dietetics at Acadia University. Her research focuses on improving nutrition and reducing health disparities among populations negatively affected by the social determinants of health. Within this area, she's particularly interested in strengthening lactation support interventions to reduce breastfeeding inequities and the investigation of household and infant food insecurity. So thank you, Jane. Looking forward to hearing what you've got to say.
Great. Thank you so much, Julia. And you can see my slides okay? Okay, yes. Great. And so thanks to Julia and the rest of the members of the Nourishing Futures Network for the invitation. And I'm really excited to talk to you about understanding and responding to early childhood food insecurity. So focusing more on the infancy stage. So we have infant feeding guidelines as really important clinical and public health strategies to promote optimal growth, development, and reductions in chronic disease. And our Canadian infant feeding recommendations really do mirror the global public health recommendations for infant feeding from the World Health Organization. So these include exclusive breastfeeding for the first 6 months of life, the introduction of iron-rich complementary foods around 6 months, and continued breastfeeding for 2 years and beyond. And our Canadian recommendations also include a vitamin D supplement for all breastfed infants. Underlying adherence to these best practices that we have are strong first food systems. And first food systems are those systems that provision food for our youngest citizens, including through breastfeeding and human milk, commercial breast milk substitutes, which I'll refer to as infant formula, and complementary foods as well. And we know infancy is this really crucial time for optimizing growth and development, as Brenda and Carmen both mentioned, and nutrition plays this really key role. So first food systems really lay the foundation for lifelong health. However, we also know that these systems don't always work well for families, and you'll see that theme come up throughout this presentation. Just as one example, despite national and global recommendations to breastfeed exclusively for 6 months, we do still have gaps between these recommendations and actual practices. So here's Canadian data, which is nationally representative. So you can see the prevalence of breastfeeding on the y-axis and the age of the baby in months on the x-axis. And so 91% of women start breastfeeding. And by 6 months, only about 69% are still providing any amount of breast milk, and only 38% are providing breast milk exclusively at 6 months. So what this means is that when we see these low rates of exclusive breastfeeding, which means providing only breast milk to the baby, there are actually a lot of families providing some amount of infant formula to their baby. And we'll talk about that in upcoming slides as well. In high-income countries, we do unfortunately have these persistent disparities in breastfeeding based on characteristics like maternal income and education, mother's age and partner status. In Canada, we have limited racial data, but well-documented differences in the US, for example. And so this slide in particular shows breastfeeding disparities based on maternal education and household income, again, from nationally representative data. So on the left, you can see on the top, this graph shows exclusive breastfeeding for at least 6 months and any breastfeeding for at least 6 months in terms of highest education level. So from these graphs, you can see there's a difference of over 10 percentage points between those with less than high school education and those with at least a high school education, so a high school education or greater. And then on the right, the same orientation, but looking at household income. And again, we see over 10 percentage point difference between the lowest income quintile and the highest. So really understanding and actually addressing these disparities, including how they change over time, was recently identified as a priority for human milk research. And in Canada, we do need a renewed focus and investment on children and families, particularly for those facing social and economic marginalization. So UNICEF does rank Canada 30 out of 38 industrialized nations for overall child well-being, and this ranking has been consistent across 2 decades of reporting. We know newcomers, racial and ethnic minorities, and Indigenous families are among the most vulnerable and fastest growing demographics in Canada. And we also know there's a wide range of perinatal health risks associated with marginalization. And these include postpartum depression, preterm birth, low rates of breastfeeding, and also household food insecurity. And as most of you are probably aware, these increased health risks are not usually experienced in isolation, and they do adversely affect health trajectories throughout life. And so for the purposes of this presentation, I will be focusing on household food insecurity as an increased health risk. So here in Canada and in the US, household food insecurity is measured the same way. So when we talk about household food insecurity, it's measured and monitored as the inadequate access to food due to financial constraints. So it can range from worrying about running out of food, actually compromising the food quality that you're eating, or going full days without food, all due to not having enough money for food. And we have been measuring it here at the national level since 2004. So we have great data, and it's measured using this standardized and validated tool. It's called the Household Food Security Survey Module, a bit of a mouthful, but it distinguishes between the experiences of adults and children. So there's an adult scale with 10 questions, and then a child scale of 8 questions is administered to households who have children under 18. And then together we can determine household food insecurity status. So we have lots of data looking at the prevalence of household food insecurity, which is great, but the numbers aren't so great. So the most recent data indicate that about a quarter of people in the 10 provinces of Canada do live in a food insecure household. And that equals 10 million food insecure individuals in our country, including 2.5 million children under 18 years of age. We do know that households with children are more likely to be food insecure than those without, particularly among single mother-led households. And we also know that people under 18 do have the highest proportion of individuals living in food insecure households than any other age group. However, this household food security survey measure might even underestimate the prevalence of childhood food insecurity, because those 8 child-focused questions don't quite capture how food insecurity might alter food access for children under 2 years of age, since children in this age group eat really specific foods and in specific ways. So for example, infants under 6 months of age will only be eating breast milk or formula or both. So then what about families with infants in terms of household food insecurity? Despite this nutritional vulnerability in the early infancy period, we currently don't have any routine assessment of infant food insecurity, including its prevalence or how caregivers cope with this. But we do have some Canadian data that's starting to unpack these gaps. We know from qualitative and quantitative data that while household food insecurity may lead mothers to start breastfeeding, it might also undermine breastfeeding success. So this study used nationally representative data from 2005 to 2014, and you can see that overall 17% of women with children less than or equal to 24 months reported household food insecurity. And what authors found in their analysis on the association between food insecurity and breastfeeding is that women with food insecurity were not less likely to start breastfeeding compared to those with food insecurity. So there is no difference in breastfeeding initiation based on food insecurity status. But in this graph here, you can see that half of women with food insecurity, this cluster of lines of red, green, and dashed, stopped exclusively breastfeeding around 2 months of age, whereas 50% of those with food security in the blue line continued exclusively breastfeeding for at least 4 months. And when they did do adjusted analyses, authors found that compared to women with food security, those with food insecurity had a significantly lower odds of exclusively breastfeeding to 4 and 6 months. And then more recently, we conducted a study investigating the association between household food insecurity and prenatal breastfeeding intentions and actual achievement of those intentions. And you can see in this sample of women from the province of Nova Scotia, which is on the east coast of Canada, 28% of women with infants 6 to 12 months of age reported household food insecurity. And we found no difference in prenatal breastfeeding intentions between food secure women and food insecure women. However, we did find that overall, within the total sample, only half achieved their intention to feed only breast milk for the first 6 months, which is quite low. And we also found that women with household food insecurity had a significantly lower odds of achieving this intention compared to food secure women. And I'm currently working on an analysis investigating the association between household food insecurity and adherence to those Canadian infant feeding guidelines. Again, using data from caregivers with children in Nova Scotia, children 0 to 24 months of age. So I will be looking at different breastfeeding practices, timing for the introduction of solids and vitamin D supplementation. But for today, I'll just share preliminary results of several breastfeeding practices. So in this sample, 30% of caregivers reported household food insecurity, so caregivers with infants 0 to 24 months of age. And I'll go through this table with you. I'm showing the total prevalence of each breastfeeding practice, and then the prevalence of each breastfeeding practice by food security status. So you can see 92% started breastfeeding, which is in line with Canadian data. 66% continued breastfeeding for at least 6 months. 56% continued breastfeeding for at least 12 months. Although I will note there's a smaller sample size for this particular metric, and that's just based on the number of respondents we received who had infants at least 12 months of age. And 31% exclusively breastfed to 6 months. And you can see in all of these metrics, those with food insecure, food insecure caregivers had a lower prevalence of breastfeeding. And when we conduct adjusted regression analyses, we do see most of these differences persist. So compared to food secure caregivers, those with household food insecurity had lower odds of breastfeeding initiation, any breastfeeding to 12 months, and exclusive breastfeeding to 6 months. So we can see from these Canadian data that household food insecurity is prevalent in households with infants, and it does impact breastfeeding practices. But what does food insecurity actually look like for infants and for families with infants? So I collaborate closely with Dr. Leslie Frank, who you all heard from, and I use her conceptualization of infant food insecurity. So our work mainly focuses on the economic and commercial drivers of infant food insecurity. So the economic drivers refer to lack of economic and social protection for sustainable breast and formula feeding. And commercial drivers refer to infant food shortages. So in this context specifically, it's related to the infant formula shortage that we experienced in North America. So this shortage started in February 2022 when one formula plant in the US had to be closed due to contamination. And at the time, Canada imported 100% of its formula from the US. So the shortage reached a crisis level in both the US and Canada. So what infant food insecurity refers to is infant vulnerability with respect to food access, suboptimal food quality, and inadequate quantity. And as part of our ongoing work to validate infant food insecurity indicators, we captured the experiences of the formula the formula shortage and insecurities related to infant feeding and economic constraint. So we had a survey in North America to capture these experiences, and I'll provide examples of both of the experiences on the upcoming slides. And so we had 918 caregivers complete the survey, and in both Canada and the US. Almost half reported household food insecurity, 87% initiated breastfeeding, and 85% experienced the infant formula shortage. So I'll walk you through this table and the ones on the coming slides. So we asked caregivers how breastfeeding was impacted by household food insecurity due to economic constraint. So all of these statements are in relation to not having enough money. For example, 30% of households felt their child was hungry while breastfeeding because the mother was not eating enough due to not having enough money for food. And you can see there's a higher prevalence among food insecure caregivers compared to food secure caregivers. And those two categories are classified based on that household food security survey module. Food insecure caregivers also had a higher prevalence of using formula while breastfeeding because the mother wasn't eating enough at 41% compared to 9% of food secure caregivers. And 65% of food insecure caregivers reported breastfeeding more, attempting to start breastfeeding or restarting breastfeeding because they couldn't afford formula. And we asked the same question in relation to the formula shortage, and 55% of food insecure caregivers did this because formula was hard to find. And in all of these cases, there's a statistically significant difference between food secure and food insecure caregivers. And you can see the difference is that there's a higher prevalence of experiencing these indicators among food insecure families. But it is important to note that food secure caregivers responded affirmatively as well. We also asked caregivers how formula feeding was impacted by both economic constraint and the formula shortage. So this table specifically shows results in relation to not being able to find formula. So for example, 83% worried about running out of formula and 42% actually did run out of formula and couldn't find more. Other compromises we asked about due to not being able to find formula included feeding something they didn't want to their child instead of formula, adding more water to the formula than the instructions say, and actually skipping or stretching feeding times. And 15% reported that they felt their child was hungry because they couldn't find formula. Again, in both of these instances, food secure and food insecure caregivers were affected, but there's that higher prevalence among food insecure caregivers who experience these compromises. And we also asked about social indicators of infant food insecurity. So those strategies that people use to actually acquire food for their infants. And as you'll see, there are compromises within the larger family, all because of a lack of money. So 34% borrowed money to help feed their child. 18% visited or stayed with someone to help feed their child. 3% stole formula or infant foods from a retail store. And 39% bought their children's food instead of paying for other basic needs. So what does this all mean for practitioners? So first of all, infant food insecurity refers to vulnerabilities related to both breastfeeding and formula feeding. So there has to be protections for both of these modes of feeding. And as practitioners, it might not be enough to check that a baby is feeding and growing, as underneath there could be significant compromises that are harming other aspects of maternal health and family well-being. So we have to be really sensitive to food insecurity when we're doing perinatal nutrition counseling, because many families just simply can't meet optimal eating patterns, including for their infants. So I think as healthcare professional groups, we can advocate for creating these first food system frameworks so that there are emergency infant feeding pathways available, and doing this alongside advocacy for income-based solutions to address food insecurity would also be a great idea. And then, as Carmen mentioned, collective action is needed across both healthcare professional groups, but also across sectors, including the government, to address this crucial issue of food insecurity during the first 2001 days. And I'll just finish off by telling you a bit about how we're trying to respond to infant food insecurity. So to date, there's been no work in Canada to build these context-specific frameworks for resilient first food systems, which are necessary to prevent infant food insecurity, protect infants' rights to food, or even guide clinical and community practice on how to support families. So we have a new project starting around now. We've just started it, where we will have decision makers, researchers, and other knowledge holders participate in a Delphi survey to really develop and prioritize both policy and practice solutions to infant food insecurity that align with the current evidence on structural drivers of infant food insecurity. And then as researchers, we'll create a cross-sector first food systems framework that identifies, contextualizes, and prioritizes solutions, and then bring this back to those who completed the Delphi survey, where we'll bring everyone together in a deliberative dialogue to gain feedback and discuss this first food system framework in a cooperative environment. And all to answer this question of how structural and social determinants create infant food insecurities, specifically in Nova Scotia, and what is necessary to prevent and mitigate their harms. So that's all from me. Thank you very much. I acknowledge my colleagues and all the funding sources as well. And you'll just see here the vast growth and development that happens from a newborn stage to a child under 2, and what their nutrition can build and grow. Thank you.
Fantastic. Thanks, Jane. I think I remember meeting your little bub at the conference last year. So yes, it's probably, yes, they're doing well now, thriving. That's great. Well, thank you so much for your presentation. Really interesting to hear about your ideas with your first food systems framework. I haven't heard of anything like that before, so that's fantastic. I look forward to hearing more about that.